And thank you to Emmett and the organizers of OIS. It's really great to be here. So Vision Medicines is focused on the retina, which is the highest growth area in ophthalmology with high unmet medical need and large market opportunities. Our strategy beyond developing our assets is to also drive a consolidation in the ophthalmology marketplace through M&A. And we believe that our industry, our sector, is ripe for that. And I'll address that near the end of the presentation. So our two programs, starting first with VM100, is a phase 2-3 ready program for geographic atrophy and intermediate AMD. Our second program, VM200, is for Stargardt disease, which is an orphan indication, which is currently in IND-enabling studies. Recently, we announced $7.5 million in non-dilutive co-funding from the Foundation Fighting Blindness, which is represented here, and we're very thankful to have them on our team. Let me talk a little bit more about our pipeline. So VM100 is a monoclonal antibody against A-beta. It is an antibody that has only been developed for AMD. It has never been in Alzheimer's patients, only in AMD patients. We are developing VM100 for geographic atrophy first. The mechanism of action is to clear retinal A-beta, in fact targeted to the oligomeric form of A-beta, which is found in the retina, as well as addressing complement. We look to initiate phase 2-3 studies in 2016 and report out proof of concept data in geographic atrophy in 2017. VM200, our second drug, is a small molecule for Stargardt disease, but is also applicable to other orphan indications. It works through an aldehyde trap mechanism. We're looking to initiate phase 1-2 studies in 2016 with readout in 2018. So just a couple of points on VM100. It is a systemic treatment, so it addresses both eyes simultaneously. In terms of dosing, we believe it can be dosed every other month or perhaps even quarterly. To date, it's been in 61 patients with either GA or intermediate AMD in 2 phase 1 studies, and there has been no safety signal found to date. So why do we believe in VM100 and A-beta as a driver here? First off, Biogen has clinically validated A-beta as a driver of Alzheimer's disease. Now, talking about the mechanism in the eye, we all know that drusen is a biomarker of risk progression to advanced AMD. And drusen contains both toxic A-beta and activated complement. If you look at post-mortem eyes of patients, about 100% of those eyes with high drusen load have retinal A-beta. And A-beta oligomers are only present in eyes with drusen. And not only is A-beta itself toxic to the retina, but A-beta promotes a pro-angiogenic environment, and it also triggers complement activation. To date, in terms of data, we have 2 anti-A-beta mAbs that have been administered systemically that decrease retinal A-beta and complement in 2 different mouse models of dry AMD. So VM100 has shown improvement in retinal structure and function, and so has another antibody that's actually a tool compound very similar to VM100 in a different model. So our strategy is to focus on geographic atrophy and intermediate AMD. VM100 works by clearing harmful A-beta and complement to preserve the retinal structure and function. If you look at the left panel here, you see the normal state with healthy photoreceptors and RPE. In the middle panel, you'll see the disease state. And let me just kind of take you through this briefly with this cartoon. So in yellow, you have drusen. And in red, you have A-beta vesicles, which contain, in green, complement. On the right panel, when you treat with VM100, you not only remove the A-beta, but also the complement. And that's been shown in the model work that we've done, or data that we have. Just one other point. In AMD, A-beta is on the blood side of the blood-retinal barrier, whereas in Alzheimer's, it's on the brain side. So it's actually much more accessible in AMD. VM100 prevents A beta and complement deposition in a mouse model, an aged APOE model for dry AMD. And I won't take you through all the data, but basically a high-fat diet serves as a switch effectively to lay down deposition of A beta and complement. And when you treat with VM100, you actually prevent the laying down of this deposition of both A beta and the activated complement, therefore preserving structure. And on the right hand, you can see the preservation of function as measured by ERG. So VM100 has been in 61 patients, either with geographic atrophy or intermediate AMD, in 2 studies, and no drug-related safety signals have been found. So we are proceeding with phase 2-3 studies starting next year. VM200, which is switching gears again, is a small molecule drug for Stargardt's disease. It treats both eyes simultaneously, obviously, as a systemic treatment. Let me tell you a little bit about Stargardt. Stargardt's is a juvenile macular degeneration. It affects about 100,000 patients in the US, EU5, and Japan, so a fairly large orphan indication. VM200 works by trapping all-trans retinol. All-trans retinol is a byproduct. And as you can see here in the top panel, which is a disc of a photoreceptor, in red is all-trans retinol, a bad byproduct. With ABCA4 flippase in all of us that are normal and don't have the disease, you can get rid of the all-trans retinol. In the second graph here, as you can see, in the disease state, because you have mutations in the ABCA4 gene in Stargardt's patients, ABCA4 is effectively rendered ineffective, and so you have a buildup of the all-trans retinol, in fact, even forming dimers like A2Es, which are quite toxic to the retina and lead to the photoreceptor death. With treatment with VM200, effectively, it acts as a neutralizing agent and buffers, if you will, all-trans retinol until it can be diffused through natural means. So the data to date shows that in a knockout model of Stargardt's disease, VM200 prevents retinal degeneration. It preserves retinal structure in a dose-dependent manner, as you can see measured by OCT on the left. And on the right, it preserves retinal function, again in a dose-dependent manner, and measured using 11-cis retinol, which is a marker for photoreceptor health. And last point I just want to make is that we believe ophthalmology is ripe for consolidation. All of us here have about, on average, 2.29 products per company. If you look at some of the more mature therapeutic areas, you get about 3 to 4 or more in your pipeline. This obviously enables better risk allocation across pipeline, but also better, more efficiency in terms of capital and human capital. Thank you very much for your time.